Welcome back to the Balance Health Information Podcast. I'm your host, Samantha Lugine. I have a special guest, Clara Ehrman, with me, longtime friend, and of course, HIM professional. In today's topic, we're going to be discussing the different parallels of HIM in healthcare facilities. Okay, that was all right. So we're going to be discussing the best practice, challenges, as well as the various locations and facility settings that we have in health information.
Great, thank you for having me.
So I know a lot of places I know a lot of individuals do not know HIM is not only in just a centralized location of hospital. We are in nursing homes. We're in outpatient settings. What else is out there? We're everywhere.
We are everywhere.
We are everywhere.
It might not be, the department might not necessarily be called HIM, but we have individuals that actually do the functions of an HIM person or an HIM professional. A lot of times it's not called HIM, and a lot of times it's called assisting administration or, whatever, you name it. But many of those individuals are really dealing with what has to do with HIM, the records, the information. And when we talk about the records, remember, the record's not just a file. It's the data is so many different places that we deal with the data.
Yes.
So
and I think that's key thing. We're not paper. We're dealing with data, and everything about data is here.
Yep.
So
yes, that is very true. Data could be found in so many different areas. The data is no longer what you used to have, a file that contains all the information about the patient. If you wanted to know anything about the patient, you had to go to that specific file.
Exactly.
Now it's not like that anymore. The data lives in so many different places.
It's more shareable.
It's
not. Which is what I love. Which is why I tell you guys I'm allergic to paper, because it's not accessible. It's not as accessible as a electronic system, and that's why I prefer that process. So when we talk about having data so accessible, we have to talk about the quality, and we have to talk about the integrity.
Absolutely. I think this is extremely important, and I don't think we talk about this enough. It is extremely important that when we collect data, the data is quality. How do we ensure the data is of quality? Well, think about this. We have so many different professionals entering documentation of the patient's health record. A lot of times you're going to find inaccuracies because many times the clinicians, the people that are documenting, may not necessarily look at the data that the other professional entered. And I think it's important to have, that understanding that when you are documenting, you are not clinicians, but we do see a lot of the information that is entered by some of the clinicians might not necessarily be accurate. You're going to have one person documenting the individual as male, so you're going to have another person documenting the patient as a female.
Yes.
Or let's say the individual doesn't identify with any of those genders.
Exactly.
You have to consider that. Again, the data might not only live in one system, and having consistency of the data is part of data quality. You have consistency in the data, regardless of which system you are capturing the data. It needs to be consistent in order for the data to be of quality.
Yes. So when we're speaking about like quality and the information, and I know you said sometimes there could be contradictory statements, or even with I don't know if I've seen, because I've coded a few charts here and there, and I will see that the admission diagnosis is one thing, and then it's another, and it's like, okay, as a coder, which one am I going to put as the primary diagnosis? Right. So we want to ensure that we have to physician query those providers. Please provide me with the most accurate information. I've worked for teaching hospitals, and it's really the medical student documenting, and then the attending, the licensed physician, is best practice, supposed to review those documents. And I'm seeing the discrepancy in that it causes a lot of confusion. So
it does.
There is
And not only causes confusion, but if you think about it, it's not just about the confusion, it's going to be errors, medical errors.
Exactly.
When someone, that's why you're going to see that when a patient is having surgery, the same question is asked over and over. And
it may sound redundant, but there's a purpose to the madness.
There's a purpose to that, absolutely. And we should not forget that. But the reason why the questions are being asked over and over is because we want to ensure that you are doing what you're supposed to do for the patient. Sometimes you're going to find inconsistencies in the diagnosis and the procedure.
Mm-hmm.
Wait, hold on. You did what? But this is the diagnosis. Okay, that doesn't match. I know that's some of the things that sometimes you're going to encounter. What happens when we find something like that? We absolutely need to query the physician. So you did that procedure, and this is the diagnosis. How does that match? Obviously, you're going to have issues, with medical necessity, because if you're doing that surgery and the organ that we're talking about is totally unrelated, how does that represent quality?
And you're talking about as documentation, right?
Absolutely.
So isn't there like a clinical decision support system that's supposed to say alert, alert, alert? This is the wrong site that is not appropriate with the procedure or the that is listed, the procedure code in the system.
But remember, the systems are going to be just as good as we make them.
Yeah,
so that's the thing. You can have a system that is very sophisticated, but one of the things that is a real thing, alert fatigue. The clinician receive a lot of alerts.
Override.
Yeah, I'm going to override that. Yeah, you can override, but you have to look at what you're doing. What are you overriding there? Are you overriding the same question that is meaningless, that is not going to have any impact? Or are you saying override and the question that you're being asked is, are you sure that you need to do the X, Y, and Z? So it's important to ensure that, and this is where we come in.
Yes.
This is where you, as an HI professional that is reviewing the record, need to say, wait a minute, the clinician documented this, but the procedure that is being performed doesn't match. That's where we come in. That's where we have to make sure that we query the physician or whoever is the person that we need to query. If it's not a physician, it's a nurse or mid-level practitioner could be. Mm-hmm. It's important to do that.
Interoperability with the information.
Okay.
So having that so basically ensuring that the data is quality and interoperability. So we're talking about different facilities. So we can have the patient going for continuation of care to their specialist or to their PCP or to another hospital for a second opinion. Mm-hmm. And having that information, like that HL7 speaking the same language, it has to be a standardized information. I know that you work for hospital setting. You work for outpatient settings as well? Am I right?
No, it's inpatient, but it's a different type of setting.
It's a different type of setting. I've only worked for insurance companies, and majority of is hospital settings. Right. But I have worked with other facilities that do need the information for their patients, such as like the specialties in cancer, outpatient cancer facilities, ophthalmology.
Right. So there's a lot going on right now when it comes to data exchange. Mm-hmm. As I mentioned, you're not only going to have interoperability within the organization, making sure that if you have 2-3 different systems that they can properly communicate with one another. And a lot of times it comes to the language that is being used, the terminology that is being used. But when we think about interoperability, we have to think it's not just about 2 systems within the organization, but from one system to the next. Exchanging information, sending information. When we talk about health information exchange, some of the challenges that you're going to encounter with health information exchange is that, let's say you collect data about a patient, and that data is transmitted to the RIO, to the HIE, and then the data is corrected. How do you transmit that data? Exactly. What systems do you have in place to ensure that the updated information is actually transmitted? It's being stored properly. It's being updated. When you don't have those systems in place to ensure that if I documented this individual saying, let's say, is African American, but now we realize the patient might review the record and says, wait a minute, you have me listed as Caucasian, but I'm actually African American. That we go and make the updates in the record, but then making sure that data, that update is transmitted to the RIO, to the system, the agency that is collecting that data.
So I'm glad you brought up the updated information, because I've noticed what has been an issue for our EMR system, and especially sending out information to other facilities for a patient, that I'm not sure why vendors or organizations or even technology systems have this, but they have an updated time frame. The document can only be updated within 60 days, and then after that, the information still it just remains the same, which I think is dangerous and irresponsible to have that.
I believe so.
I know I have gone into facilities and said, turn that off. Because if the discharge summary is stating a certain information and then it has been updated, even something as simple as the physician now signed the document. But yes, we know that there's the state and the federal regulations that the document needs to be signed within 30 days after the patient is discharged, right? Sometimes, because providers do get busy, so I don't want to, penalize them too much for that. But the document is not signed until after that 30-day frame. So not having that document being able to update is kind of like, I'm not sure why anybody thought, okay, let's put a stipulation that occurs. So with the information exchange, I'm sure there is do you want them to have the providers in compliance, that you want to put that rule in there, but sometimes it's just not realistic and it's actually hurtful.
Right. I agree. It's again, the information that we're talking about is not just about clinical information, but it could be demographic information. Sometimes you may have the wrong social security number. The last digit is wrong, or one of the digits is wrong. And if you need to update that information, you should be able to do it regardless of it's 60 days, 90 days, or a year, whatever.
And then it should be able to transmit into the next system.
And update the system, absolutely.
So I've always found that issue. You said demographics. We also have issues with patient name. You mentioned sex. There's birthday that could be incorrect. And you can imagine how many times I've had patients come in and say, my birthday is wrong. Right. Or it could be any kind of those dates are wrong. And then it's been years later. Right. And then we're having an issue to now update that information, but the system states that it will be going forward. It does not backdate. Yeah. So that's kind of an issue.
Again, there's many challenges that we're still facing. We thought that with the implementation of medical records, electronic medical records, all the problems are going to be solved. That's far from the truth. Because now we have the data, in a way, if you think about it, when you had a paper record, it was in one place. You could do it right all in there and it was done. It was corrected because you have it in one place. But now that the data lives in so many different systems, you have to take in consideration that when you make the change in one system, you should be able to update all systems. We are not there yet. I think, we are working towards that.
We got some ways to go.
But we definitely have some ways to go to ensure that we have a system that it can communicate, throughout, without just in one facility or from one facility to the next. It should be able to do it anywhere.
Yeah.
So, a universal health record system, let's say.
Does Europe have that?
No.
Canada. Canada has universal health record system.
Honestly, I'm not sure.
I believe Canada has universal health record system.
That's a good topic.
That's a good topic. Thank you for bringing that
up. Let's research and talk about it. Maybe you find somebody that knows a little bit more, and we can discuss that.
Yeah, but I am interested. How does the universal health record work?
Yeah,
that would be interesting.
I don't know.
So, speaking of universal health record system and exchanging information, security and privacy is an issue still, but at the same time, we have made some great strides. We have to think about data breaches. We have to think about cyber attacks. We have to think about all these things. HIPAA. Yeah. We have to. All those things have to be incorporated when we're talking about different information being transmitted from HIM to different departments, different facilities.
I do find that a lot of times, many of the issues that we find, we all know that when you click on that wrong link, you can bring anything down.
Who knows? Yeah.
But I think we need to promote more and make it more. It's not just if you made a mistake, if you click on the wrong link, oh my God, you're going to be terminated, you're going to be fired.
Exactly.
It should be more an education.
That's what I agree.
And obviously make it clear to everybody, you do not want to click on the wrong link. You definitely don't want to do that. But if you did, don't be afraid to call IT. Don't be afraid to call the people that you need to let them know. It is easier if you do it that way. A lot of people, they know that they click in the wrong link and they will be like, oh, I don't say anything. I hope that nobody finds out that it was me. But eventually it comes out. So It's best to educate the staff about the importance of being transparent and being able to say, you know what? I received an email and I clicked on the wrong link. I've done it, and I've sent it to IT compliance.
I'm like, nope, I don't, because I wanted to get to the root cause in case it does. Yes. I don't want it to spread anywhere else. So I've done it too,
and the hackers have become so savvy.
Oh, they're so smart.
They know how to get you.
We're watching you, hackers.
Yeah, that invoice, that oh, it says here you have an open invoice. Oh, I forgot, I haven't paid that invoice, I guess. And you click on it and it's like, okay, I knew that was wrong.
Exactly.
And sometimes, we're busy, we quickly want to click on that link. Oh, let me see what that is. And we just need to take a little step back and say, let's just be careful. Let's not do it. But again, having the staff being aware of what the steps that they can take to mitigate, the risk that this will represent for the organization is important. Just it should be part of the education of every employee. When they, they first get hired.
Yeah, the onboarding process.
Right. Let them know that, if we don't want you to make a mistake in terms of clicking on the wrong link. Obviously, the organization needs to have policies and procedures in place on what access do they have, what, there's different things that you can do. But if they do make a mistake, they shouldn't be afraid that I'm going to be fired.
Exactly.
You want to make sure that you can tell someone, I made a mistake, please help me, figure it out. Can we fix it?
Exactly. I know that companies send broadcasts of alerts of phishing, and any if you see something, please do not click on it if it is suspicious.
Right.
So I think that it's great that there's broadcast continuation or, basically a reminder, repetitive to get into the groove of, okay, I have to pay attention to who's sending me an email. Right. I know with Microsoft 360 Outlook, they now say you do not receive emails from this recipient often. Right. And I love that because this alert is like, okay, let me pay attention. That, other companies have made it easier for organizations to be able to be alert on what's an appropriate email for me to click on and what's not. Right. Can it be alarming? Yes. Can it be scary? Yes. Yeah, but it's always better to be forthcoming with that information.
I agree.
Instead of hiding it, because you just never know. I think I've heard, I don't think the stories are that funny, but jokes. Oh, the person clicked on the wrong email and then the cyber attack has taken over and ransom of all your medical records. It's like, why that extreme? Why that fear?
Right. Yeah. It's we want the staff to know that if you click on it, yes, this could have a tremendous impact on the organization. But you also want them to know the sooner you say something, the better. We're going to be able to maybe contain the whole, attack maybe somewhere. But if you don't say anything, that might be a possibility that we're going to bring the whole system down.
Exactly.
Which we don't want to do.
So when we so of course we can't talk about security and privacy without regulatory compliance, and I know that's your expertise. Yes. So when discussing that, any challenges with creating the regulation process, and who do you work with? Do you work closely with IT? Like, I would like to know all of that, because I feel like IT.
I do, and at times people think I work in IT. I'm like, no, I don't work in IT, but I do a little bit of here and there. The fact that I guess I have some technical skills and can help people, like, okay,
helpful.
I forgot my password in this system. Okay, hold on, I can reset your password, whatever. So people think I work in IT, but I don't. or I might log into the system remotely. Okay, click here, click there. Oh, the IT person, the IT girl.
No.
But I help them out. So when it comes to regulations, we all have to follow different regulations, obviously, federal and state regulations. And depending on the type of facility that you work with, depending on the settings, that you work, you may have different regulatory agencies that you need to comply with. You may have different regulations that apply to your facility. Integrating.
Pause a little bit. The different regulations that facilities that Clara is discussing. There could be the Joint Commission. There could be OASIS, outcome of assessment. All these things that
Office of Alcoholism and Substance Abuse. Yes.
There's CARF for the rehab. There's just different, and ED has regulations as well. So I just want to put it out there. These are all things that I teach that I remember the acronyms: DEEDS, EADS, MDS. But yeah.
So it's different. You're talking about different types of data sets that you need to collect data from different types of settings, from different types of facilities.
Yes.
But when it comes to regulations, you have to think that an accrediting body is not the same as a regulatory body.
Yeah.
So, for example, when it comes to CARF and Joint Commission and DEEDS, DEEDS is actually that is a data set.
That is a data set. But there's one with the D and G, something like that.
Yes, I know which one you're talking about. Don't ask me to remember
that.
But when it comes to, for example, Joint Commission and CARD, just to think about a couple of them, those are not necessarily a regulatory body, but they are an accrediting organization that set up standards, and the hospital, the facility that is accredited by that entity needs to comply with those standards, right? But when it comes to regulations, the regulations are usually, state, federal regulations that you need to follow. For the most part, the accrediting body is always going to follow what the regulatory agency creates.
Just as the OH.
Right. So, for example, when it comes to a hospital that's accredited by Joint Commission, right? The hospital is accredited by Joint Commission, but the regulation comes from federal state regulations. There's different ones, of course, but CMS grants Joint Commission authority to do their review for the organization, and if the organization is in compliance, for the most part, then they're going to be in compliance with CMS. That's because Joint Commission has deeming authority to say, yes, this organization is in compliance, so you don't have to do another inspection, another survey with CMS, for example. So having an understanding of how a regulatory body and a accrediting body work and what is the role of those two is important. I think a lot of times one of the things that I find in my field, so I work for a substance abuse facility, and our accrediting body is CARD. Different organizations may have another type of accreditation, but we are accredited by CARD. Our regulations come from OASIS and sanction. Okay, so CARD follow what the regulatory agencies are doing in order to create the standards, because and sometimes you're going to have that a accrediting organization may have some requirements that might be a little bit different from the regulation, but they should never truncate what the regulation mandates. So I think a lot of HR professionals sometimes don't have that understanding of the difference with what is an accreditation, and I shouldn't say a lot, but some HR professionals
I think it's used like interchangeably. It gets a little bit confused because even sometimes I'm like, and then I'm like, I just follow all the regulations.
So let me tell you one of the things that is interesting that I think would be interesting to you. So now I am in the process of becoming a CARD auditor.
Oh, that's great.
We're not called auditor. It's a surveyor, right? Because we can't say what I just said before, because that's very different. CARD, for example, those that want us to use the word regulation. Compliance is conformance with the standards.
Conform.
You need to go
is it less? Is a softer blow?
It is. And but I think it's interesting to have that distinction of what they mean and all that. So one of the things that I was thinking about that I wanted to put out there, that there's so many different regulations. Obviously, you have state and federal regulations, right? And one of the things that I find in my field when it comes to not necessarily just HR professionals, but clinicians in general, when they come to the facility, and I usually meet with every new employee to talk about regulations, to talk about compliance process, to talk about policies, to ensure that the employees feel that they have somebody to talk to. It's not just a video that they watch, but that if they have a question, that they can reach out to me and all that. But one of the things that I find very interesting is that a lot of the people that come into work in the facility, the majority of them know about HIPAA. They know about a HIPAA privacy rule. But I want to say 80% of the people that come to work for the organization have no idea about another federal regulation that is very, very important, that is called the 42 CFR Part 2, which is the main regulation that substance abuse have to follow, because that is very specific to substance abuse. The HIPAA privacy rule is a federal regulation, and so is the 42 CFR Part 2. But I find it very interesting that a lot of people do not know too much about it. And a lot of times they ask me, oh, yeah, I know everything about HIPAA. I'm like, okay.
I think it's a testament to the basically changing the onboarding, because onboarding, there is a section for HIPAA. but there should be subcategories of mentioning the 42 CFR. I'm not sure why we only just keep it surface level, really.
Right.
When
I think it's because, again, well, let's put it this way: there's no regulations out there that are trying to align more the HIPAA privacy rule with the 42 CFR Part 2, because there's a lot of misconception when it comes to the 42 CFR Part 2. For instance, it is very restrictive. It's much more restrictive than HIPAA. And one of the things that happens is a lot of people think that because you have to follow the 42 CFR Part 2 regulations, you can't provide patients access to the records, which is not necessarily the intent of the regulation. You still need to provide access to the patient information. There's other requirements. For instance, let me just give you an example. If you have a patient that is admitted to your hospital and I come to visit that patient, right? I will come to the front desk and I say, "Hi, I'm here to visit my grandmother, Joanne Smith," let's say. They're going to ask me, "Oh, what's your name?" They're going to ask me my name, and they are going to give me a pass, and they're going to tell me, "Oh, yes, she's in room number 402. Mm-hmm. Take the elevator to the second floor, make a right, make a left, whatever." And they tell me how to get there.
Exactly.
Okay. The reason why facilities are permitted to do that is because under the HIPAA privacy rule, there's nothing that says that you cannot provide limited information. For example, that the patient is admitted or that the patient is not, the room number, something like that, unless
the patient opts out
exactly
of the directory.
But when it comes to the 42 CFR Part 2, the regulation is very clear that you're not permitted to disclose information if the patient is there, is not there. You cannot even say, "No, this patient is not here." The 42 CFR Part 2 says that you're not permitted to share that information with the presence or the absence of the patient in the facility. Why? Because there's all the implications. There's a lot of stigma when it comes to substance abuse. Somebody has a substance abuse diagnosis, and a lot of people get discriminated based on that. Mm-hmm. And for that reason, the regulation is so stringent, so I guess protective of the patient's privacy. So I think it's an interesting fact that I find it fascinating that so many people that they, even people that are in the field of substance abuse, they're very they're not savvy about this regulation. They kind of don't know much about it. So I think it's important to have an understanding. I think, in my opinion, HI professionals need to be very well versed in those type of different regulations. And I guess the reason why it's so there's not so widely spread that we talk about different regulations is because it has been that an HI professional works in a hospital. But like I said, we are found everywhere.
Yes.
There's all the type of regulations when it comes to HIV. Different states have different requirements. So it's important to talk about regulations. I think it's extremely important that an HI professional is savvy of those different regulations and to be able to work in any type of environment, any type of setting.
So I think because we do have a section in the HIM program, the HIT program, mm-hmm. of corporate compliance and health, legal, and reimbursement and all that. I think that should be more embedded because I don't think I've ever recalled teaching that in my other programs. I mean, I do more in HIPAA and the privacy rules and but I haven't really dived into it, to be honest, with students. And even, like I said, when we're doing onboarding for staff, it's not really dived into it as well. It's kind of something you learn as you go. And I think it would be best to at least, speak more about it, make it more common that is, I am familiar with that regulation. I'm not too much in the known of the detail, but at least I know of it, that I know that I can read and research it in greater detail.
Actually, one of the things that we do in class in the program, one of the things that we do is I believe that don't quote me this, but I think in the law and ethics course we do have actually a project, because I remember designing that project in which the students, or maybe it's another course, I don't know, but you have the students research different regulations for different type of settings and look at the different type of policies that you may have to institute in different settings. So putting that out there is important for the students to practice, for the students to become familiar with the different. We're not going to know all of them because there's so many of them, so many regulations, but having an understanding of some basic regulations is very important, I think.
Yeah. And I think that that gives me more of a a way for me to improve as I'm teaching as a professor that I should have, because I don't teach the legal and compliance, but I teach the other courses like data analytics and intro to health information. I need to incorporate that more into that because we should be discussing it not just in just one course. It should intertwine with each other and be repetitive because repetitive commits to memory. So this was really great, Clara. We discussed compliance, we discussed security, privacy. I think we even went into more detail that we weren't even expecting to get into, but of course that's what I love about
time flies when you're having fun.
Time flies when you're having
talking about what you're passionate about. I'm very passionate about it.
I am
as well. So
that's why we connect so well, because we're both so we have a love for our profession, and I would never want to leave this world. I'm glad that I fell into it. This is something that I didn't know, but I'm glad that I love to spread it around and tell everyone about this, and hopefully we can, get more people to come into our field.
Yes. That'd be great.
That'd be great.
I think we all have the responsibility to elevate our profession.
Yes.
And doing what you are doing, podcast, and we talk about topics on HIM. It's extremely important, and I hope that more people do this. I hope that the people follow what you're doing. So
thank you.
It's a good thing.
Thank you, everyone. Have a good day, and I hope to see you guys soon.